after it ran its course, we just built the very same program that was in place before, that's completely independent of any PBM, any private equity. We built the new and improved third-party program, which we call ServRx. And we've been running this company now for about 13 years.
Oh, wow.
And working with community pharmacies all over the country. And it's getting harder and harder because those PBMs keep, forcing people into networks, and they keep bundling those networks. And as we start to talk about, true transparency in PBM contracts, you talk about those gag clauses. So this was clear back in 2013, 2014, somewhere in that era. That was before the gag clauses got removed out of even the pharmacy contracts. So that didn't happen until 2018, right?
Okay.
So up until 2018, a pharmacist couldn't tell their patient, I know you have a copay here of $34.75, but the cash price is only $12. They couldn't tell a patient that. They were contractually obligated to collect that copay to make the pharmacy benefit manager billions of dollars. Yeah. So that was 2018. That finally got removed. I think the next big opportunity for true transparency is getting that unbundled. Unbundle those networks, because they're not the same. It is absolutely not the same to process a Medicare script or a healthcare script as it is to process a workers' comp. It's not the same program, and you can't treat it the same.
Right. So ServRx is doing workers' comp with pharmacies. So can you explain that? Explain that how that would. So I'm a pharmacy who doesn't know anything about what you do. Tell me how that works.
Yeah. So we step in as a third-party claims administrator for any patient that walks in and says, I got hurt on the job. For any patient that walks in on crutches or arm in a sling, you hope the staff, says, hey, God, what happened to you? And you ask a couple of questions, because they may not even know their rights as an injured worker. So we step in, give them a BIN, PCN, just like any other payer plan that they can use as the default processor. So on that day one, most patients don't have any kind of a PBM card or anything to even give the pharmacy. So they now have our BIN, PCN. Doesn't cost them anything to set up the plan. We're contracted with all their PSAOs, so they're probably already under contract. If they're not, then they just do a claims assignment agreement with us, but it doesn't cost them anything at all. It does cost them probably about $50 or $60 if they don't use us, because that's how much more we're reimbursing them than the PBM contract.
So how can you reimburse more?
Because we bill at the state fee schedule. So whatever the state of jurisdiction, wherever the injury occurred, we then bill at whatever that state has established. So the State Industrial Commission establishes what the usual and customary reimbursement is for that NDC in that state based on the fee schedule. So we bill at that and pass that on to, in most cases, it's like, 85% of whatever that fee schedule is. So we have this little 15, we never get that. We usually operate off of like a 6 or 7% margin after collections, because we have some bad debt in there. But we guarantee them that payment up front. They get it in 30 days, even though it may take us 120 days, 6 months, 2 years to collect on that. We've made the pharmacy whole up front. So yeah, it's absolutely no cost to them, but it's a cost if they don't use us.
Right.
And so that's why they do like to use us.
And so the other PBMs that are doing that, maybe the X company you work for, they're paying based on their normal PBM rate, and they're pocketing the difference between that state rate and what they're paying.
Yeah. In workers' compensation, it's anywhere from $80 to $120 that the PBM is putting in their own pocket. So the pharmacy that bought the medication, that has the staff, that has the overhead of a facility, electricity, everything, they get $4. The PBM gets $100.